Welcome to Unintended Consequences, episode 35. We're looking at a case today where the people involved were doing their best with the information they had. Millions of women took hormone replacement therapy to prevent heart disease and stay youthful until one trial showed it raised their risks of cancer, stroke, and heart attack instead. In the summer of 2002, more than 6 million American women were taking some form of hormone replacement therapy. Many of them were using it for reasons that had little to do with hot flashes. Then, on July 9th, the Data Safety Monitoring Board halted the largest part of the Women's Health Initiative trial 3 years early. The reason was not ambiguous. Combined estrogen and progestin increased the incidence of invasive breast cancer, coronary heart disease, stroke, and pulmonary embolism. The same regimen that physicians had prescribed to protect aging hearts had instead produced measurable harm. The modern use of menopausal hormone therapy began with a clear clinical problem. The sudden loss of ovarian estrogen produced vasomotor symptoms, sleep disruption, and accelerated bone loss. Consider what that loss actually meant in practice. Without the estrogen that the ovaries had supplied, many women experienced sudden temperature spikes and night sweats that interrupted sleep night after night. At the same time, bone mineral density began to decline at a faster rate than before menopause, raising the lifetime probability of fractures. In 1966, Brooklyn gynecologist Robert A. Wilson published Feminine Forever. He argued that estrogen deficiency was a treatable disease state rather than a natural transition. Pharmaceutical companies developed conjugated equine estrogens, known as Premarin, and later combined regimens that added progestin to protect the uterus. By the late 1980s, observational studies, such as the Nurses' Health Study, suggested that women who chose to take estrogen after menopause experienced roughly 40 to 50% fewer coronary events. That figure, if taken at face value, implied that for every 100 women who would otherwise have had a heart attack or angina episode, only 50 to 60 would experience one while on therapy. Medical societies therefore began to frame long-term hormone use as a preventive strategy against osteoporosis and cardiovascular disease. These conditions together accounted for the majority of deaths in older women. At the time, no large randomized trial had tested that framing. One obvious objection was whether healthier women were simply more likely to start and continue therapy. Yet the size of the reported difference made many clinicians set that concern aside for the moment. Between 1982 and 1992, annual U.S. prescriptions for non-contraceptive estrogens rose from roughly 15 million to more than 30 million. That doubling occurred over a single decade. The Food and Drug Administration expanded the label in 1992 to include osteoporosis prevention. Many clinicians extended the indication further to presumed cardioprotection. Academic centers and industry-sponsored continuing education programs presented hormone therapy as standard care for healthy postmenopausal women. A 1995 survey of U.S. physicians found that more than 80% recommended estrogen to asymptomatic patients with a family history of heart disease. Skeptics existed. Some epidemiologists noted that women who took hormones also tended to have higher education and better access to care. Yet the prevailing view held that the observational benefit was large enough to outweigh uncertain risks. The arithmetic seemed straightforward at the time. If coronary events dropped by roughly 40 to 50% in the women who took estrogen, and if cardiovascular disease caused most deaths after age 65, then withholding therapy looked like the greater harm. The Women's Health Initiative enrolled 16,608 women aged 50 to 79 with an intact uterus. Researchers randomized them to daily conjugated equine estrogen plus medroxyprogesterone acetate or placebo. After 5.2 years, the hazard ratio for coronary heart disease was 1.29. In plain terms, that meant the rate of new coronary events was 29% higher in the hormone group than in the placebo group. The hazard ratio for stroke was 1.41, indicating a 41% increase. The hazard ratio for pulmonary embolism was 2.13, more than doubling the risk. The hazard ratio for invasive breast cancer was 1.26, a 26% rise. Absolute excess risks were modest. There were 8 additional coronary events, 8 additional strokes, and 8 additional breast cancers per 10,000 women per year. These risks appeared in a population that had been told the therapy was protective. Because most participants were more than a decade past menopause, the trial could not distinguish whether earlier initiation would have produced different results. One might ask whether the numbers would have looked better if the average participant had begun therapy at age 51 instead of age 63. The study design simply did not allow that comparison. The sudden reversal triggered an estimated 50% drop in U.S. hormone prescriptions within 18 months. Subsequent observational data suggested that women who had started therapy near the time of menopause experienced different risk profiles. Yet the blanket recommendation had already collapsed. Many patients who might have benefited for short-term symptom relief stopped treatment. Others continued without clear guidance on duration or formulation. Professional societies quickly narrowed indications to the lowest effective dose for the shortest necessary time. They focused on vasomotor symptoms. The Food and Drug Administration added black box warnings in 2003. Over the following decade, reanalyses of the Women's Health Initiative data, stratified by age and years since menopause, showed that women aged 50 to 59 who began therapy closer to menopause had no excess coronary risk. They showed possible benefit for all-cause mortality. European regulators reached similar conclusions. Today, guidelines from the North American Menopause Society and the Endocrine Society emphasize individualized decisions rather than universal prevention. The episode also prompted larger investments in comparative effectiveness research on different estrogen routes and doses. This created an indirect but durable shift in how menopausal care is studied. Large-scale observational patterns can mislead when healthier or wealthier patients are more likely to receive the intervention under study. Translating risk reduction observed in one demographic group to an entire population can produce net harm once absolute risks are measured in randomized settings. Abrupt withdrawal of a widely used therapy can itself leave patients without viable alternatives until new evidence accumulates. The question that remains is how medicine can design trials early enough and stratify them finely enough to separate the patients who gain from those who lose before millions begin treatment. That's unintended consequences for today. If this episode gave you something to think about, share it with a friend who'd appreciate the story. Subscribe wherever you listen, and we'll be back tomorrow with another case. And before you go, this show is part of the NARA Network, a family of daily podcasts covering tech, science, markets, and more. If you enjoyed today's episode, give environmental intelligence a listen, the Environment and Climate Policy Brief for Canada. You can explore the whole lineup at naranetwork.com. This episode used AI voice synthesis of my voice. Editorial selection and analysis are my own.